Hello and welcome. I'm Christopher Medina DO, and today we'll be exploring one of the most foundational elements of osteopathic medicine, palpation and anatomic landmarks. This session will introduce you to the philosophy, physiology, and practical application of palpatory skill. Let's get started. By the end of this presentation, you should be able to define palpation and its clinical role, describe how the sense of touch works physiologically and emotionally, outline the layer-by-layer palpatory approach, identify key categories of anatomic landmarks, and explain how palpatory skill develops with time and experience. In osteopathic medicine, touch is more than a physical act. It's diagnostic, therapeutic, and deeply relational. We touch to gather information, to restore motion, and to communicate care. As A.T. Still emphasized, the human hand, when trained, is capable of incredible perception. To touch is also to be touched. Every contact has the potential to be clinically meaningful. Let's take a look at how your body processes touch. Specialized sensory receptors in the skin and deeper tissues translate pressure, vibration, stretch, and texture into neural signals. These include Merkel discs, Meissner corpuscles, Pacinian corpuscles, and Ruffini endings. Each receptor has a preferred stimulus and location. For example, Merkel discs respond to shape and texture, while Pacinian corpuscles sense high-frequency vibration. This combination of inputs forms a sensory map that your brain interprets during palpation. This diagram shows where these receptors reside in the skin and connective tissues. Note the superficial placement of Meissner and Merkel receptors compared to the deeper locations of Ruffini and Pacinian. These layered inputs help us distinguish subtle differences during palpation, from light texture to deep resistance. Palpation is defined as the application of variable manual pressure to the surface of the body for the purpose of determining the shape, size, consistency, position, inherent motility, and the health of the tissues beneath. But it's more than that. Palpation can be thought of as touch with a question. De Giovanna described it as a light placement of hands or fingers as an act of discovery. You're asking the body to show you what's going on, and your hands are listening for the answer. This is a two-way interaction. Different parts of your hands are better suited for specific types of palpation. The pads of your fingers give you fine tactile discrimination. The dorsum of your second, third, and fourth fingers are more sensitive to temperature. Your palm and metacarpal phalangeal joints can sense shape and resistance, and your finger interphalangeal joints are useful for detecting subtle motion. Learn how to use each part of your hand with intention. Here, you can see a color-coded diagram of the hand zones. This helps reinforce which parts of the hand are optimal for different types of palpation. For example, use your fingertips to assess texture and your palms to evaluate size or contour. Learning how to position your hand will improve the sensitivity of your exam. Effective palpation begins with relaxation. If you or your patient are tense, your perception will be limited. Contact should be broad and steady, with minimum unnecessary pressure. Avoid poking or stirring the tissues. Move slowly and allow your attention to be focused like a conductor listening to a complex orchestra. Over time, your hands will filter out noise and detect meaningful change. A structured approach helps you interpret what you're feeling. Start with observation. Then assess skin temperature and texture. Next, engage the fascia, followed by the underlying muscle. Finally, evaluate tendon, ligament, and bone. Each layer has its own feel and quality. Developing this sequence gives you confidence and precision. To train your sensitivity, use simple exercises. Try feeling a hair beneath a single sheet of paper, or sort coins without looking. These activities build tactile discrimination. Compare your dominant and non-dominant hands. Palpate familiar anatomy and focus on consistency. Every repetition builds your internal palpatory archive. Palpation helps identify somatic dysfunction. The acronym TART stands for tissue texture changes, asymmetry, restriction of motion, and tenderness. These are foundational indicators of the presence of somatic dysfunction. We'll explore how to interpret and classify these findings in more detail in an upcoming session. For now, focus on being aware of what feels normal versus what stands out. Landmarks help orient us during the exam. These include bony structures, joint spaces, muscle groups, fascial planes, and reflex zones. Each one provides reference points that guide diagnosis and treatment. Being able to identify these consistently is the basis for accurate palpation and structural assessment. Some commonly used landmarks include C7, T3 at the scapular spine, L4 at the iliac crest, the anterior superior iliac spine, or ASIS, the posterior superior iliac spine, or PSIS, the mastoid process, clavicles, greater trochanter, and medial and lateral malleoli. As you work with your colleagues in lab and with your future patients, locating and palpating these with consistency is a core skill. But palpation isn't an isolated skill, it supports your clinical reasoning. For example, asymmetry and ropiness at T7 may suggest a viscerosomatic reflex or a postural adaptation. Integrating palpation with observation, motion testing, and history taking allows you to form meaningful diagnoses and apply targeted OMT. In summary, palpation is central to osteopathic practice. It requires anatomical knowledge, refined sensory perception, and focused attention. With repetition, your hands become sensitive and selective instruments. You will learn to listen with them, to detect health and dysfunction, and to respond with care. Thank you for your attention. I look forward to helping you develop your skills in lab and in the clinical setting as we practice these foundational techniques together.